Welcome. This session is refresher mandatory training for staff providing direct patient care. By the end of this session, you will have up-to-date information about national and local issues within our organisation, our performance targets against key infections and what is meant by the term healthcare-associated infection. I will also provide you with refresher knowledge about the chain of infection and what you can do within your practice to break this chain, and a reminder about the route of transmission for organisms, alert organisms and infection risk to inform your practice for the safe management of infection. You should understand your role and responsibility for cleaning and decontamination of the environment and care equipment and the use of single-use items. Finally, you should know where to find further information and advice. NUH staff provide a high standard of safe care to ensure our patients have a good experience during their hospital stay. Maintaining a high standard of infection prevention and control has a positive impact on reducing the risk of a patient acquiring a preventable infection whilst they're in our care. In turn, this can reduce length of stay, extra hospital costs, a reduction in our workload and improve patient outcomes. You have a duty to understand and follow the relevant NUH policies and procedures to keep you and our patients safe and reduce infection. The main aim is to prevent healthcare-associated infection. Generally, these are infections that develop 48 hours following admission. It's therefore important that you understand and follow NUH policies and procedures, which you can find on the intranet. You can also seek further advice from the Infection Prevention and Control team. It is important that you understand the chain of infection and how to break this chain to prevent healthcare-acquired infection occurring. The transmission of infection depends on each link being intact for an infectious organism to spread from one person to another. Break the chain with simple but effective practice such as cleaning of the environment and good hand hygiene. The next two slides will demonstrate how to undertake the correct hand hygiene technique.
Hand hygiene is the single most important factor in reducing the spread of healthcare-associated infection. Performing hand hygiene reduces the amount of organisms on our hands. You must ensure patients are not put at risk from organisms on your hands. The World Health Organization 5 Moments for Hand Hygiene directs staff when to perform hand hygiene. You should perform hand hygiene before and after touching a patient, when leaving a patient's bed area, prior to an aseptic procedure, and if you may have come into contact with blood or body fluids. Because hand hygiene is so important, the Trust audits compliance. These audits focus on clinical care delivered in the clinical environment. The audits are performed bi-monthly over a 2-week period, and the results are presented and discussed at a monthly meeting attended by the Chief Executive and the Medical Director. You have a responsibility to ensure you understand and implement appropriate hand hygiene. Non-compliance will be challenged. Hand hygiene can be performed using soap and water or alcohol hand rub. You should always ensure you wash your hands with soap and water if they are visibly dirty. Certain infections mean you should wash with soap and water, such as Clostridium difficile. This short film will demonstrate the correct hand wash technique, which should be used whether you are using the alcohol rub or soap and water. The technique is used to ensure all areas of the hands are washed. You will undergo a hand hygiene assessment in the clinical area, which will ensure you are performing the technique appropriately. To demonstrate how effective the technique is and the importance of adhering to the concept of bare below the elbow, we will use a glow and tell machine. As you can see, the member of staff is wearing long sleeves and a stoned ring. The member of staff is now applying a special hand lotion which will glow under ultraviolet light. If any lotion is not removed during hand washing, it will glow when the hands are placed back under the light. The member of staff will now wash their hands in a casual manner. When in a clinical area, long sleeves must not be worn and only a plain wedding band or religious bangle is to be worn. No other finger or wrist jewellery is permitted. Nails should be short and clean with no false nails or varnish. This is to facilitate good hand hygiene. This is referred to as bare below the elbows and must be adhered to in a clinical area. As you can see, the area around the wrist where the long sleeves end and around the stoned ring are glowing with lotion which was not removed due to a poor hand washing technique. The member of staff will now roll up their sleeves and remove their ring to allow effective hand washing and wash their hands using the technique. If your hands suffer from dryness, itching or redness when using the hand hygiene products, you should discuss this with your line manager and seek advice from occupational health. You can now see the lotion on the hands. The technique is designed to ensure all areas of the hands are cleaned. Hands should be wet prior to applying soap. Palms are rubbed together with fingers together. The palm is then rubbed over the back of the opposite palm with fingers interlaced. The palms are rubbed together with fingers interlaced. The backs of fingers are rubbed against the opposite palm. Each thumb is rubbed into the opposing hand using a rotational motion. The fingers are rubbed into the opposing palm. Finally, rub around each wrist. The technique should take a minimum of 15 to 20 seconds to perform. All residue should be washed off the hands, the taps turned off without your hands touching the taps, and all areas of the hands dried thoroughly. As you can see, the areas which previously glowed due to the lotion remaining are now clear. Using this technique and being bare below the elbow has facilitated a good hand hygiene technique.
This slide illustrates the routes of transmission for infectious organisms. If we can understand the different ways an infectious organism can enter the body, we can put in place measures to prevent this occurring and prevent spread to others. Personal protective equipment is available in every clinical area. You must risk assess when to use this and select appropriate protection to prevent cross-transmission of organisms. Always assume bodily fluids are infectious and wear gloves and apron when dealing with such. Remember to wash your hands after removing personal protective equipment. If you obtain an inoculation injury, mouth or eye splash, you must follow NUH policy for inoculation injury and report the incident. Aseptic non-touch technique involves a set of principles to prevent contamination from the healthcare worker's hands during procedures where the patient's natural defences are breached. It includes the identification of key parts and sites. You need to consider how to proceed and what equipment you will need to perform an aseptic non-touch technique in order to reduce the risk of introducing an infectious agent and to maintain the safety of patients in our care. The special precautions illustrated here relate to the route of transmission for a transmissible organism and tie in with the relevant policy for how to manage them safely, using measures such as wearing personal protective equipment, hand hygiene and cleaning. The colour code reflects the route of transmission and should be placed at eye level on the door of a patient isolated. The next few slides are to refresh your knowledge on MRSA and how to manage patients who are found to have carriage. MRSA is a common coloniser of the skin and usually lives quite harmlessly. However, this organism is resistant to flucloxacillin and has the potential to cause a serious bloodstream infection. It can be passed around on healthcare workers' hands and contaminate the environment. Slide 13. It is important that you follow the MRSA screening and decolonisation protocol, which is available on the intranet, and follow the MRSA policy to screen patients who meet these criteria within 48 hours of hospital admission. Previous investigations at NUH into the cause of MRSA bloodstream infections include decolonisation not being signed as being given or decolonisation not being prescribed prior to insertion of a central line. Patients previously known to have MRSA carriage will require a full screen on admission, wound and skin precautions, and the commencement of decolonisation treatment. The screening and decolonisation protocol includes any adult patient outside AICU or the critical care unit who has had one of the following invasive procedures listed on this slide. These patients should ideally commence decolonisation 48 hours prior to the procedure or at the earliest opportunity. When undertaking an MRSA screen, include any wounds or invasive devices present, such as PEG sites. Obtain a sputum specimen if the patient is productive, and a CSU if the patient has a urinary catheter. To prevent a delay in diagnosis, specimens should be taken in a timely manner and sent to the microbiology lab clearly labelled with patient details. Decolonisation treatment includes an antibiotic nasal ointment, which must be applied to the anterior nares 3 times daily, and an antiseptic skin wash, which should be applied neat on a washcloth and the skin cleansed daily. Hair should be washed twice during the 5-day course of treatment. Wound and skin precautions should be commenced at the bedside. If a patient has confirmed MRSA, they must be isolated in a side room with wound and skin precautions and decolonisation. They should have their screen results explained to them and be provided with an MRSA information leaflet. Some patients with MRSA infection require specific antibiotic treatment as per the Trust antibiotic guidelines or microbiology advice. While the patient remains in hospital, they are required to have 3 sets of clearance screens taken at weekly intervals following decolonisation treatment. The side room must undergo a claw clean and change of curtains once precautions are discontinued. All cases of MRSA bloodstream infection have to be reported to our regulators, and our target is 0. This slide illustrates how we have successfully reduced the number of cases of infection by implementing measures such as screening, decolonisation, isolation and hand hygiene. The number of cases of Clostridium difficile infection, or C. diff, is another key infection which must be reported to our regulators. The next few slides will explain C. diff in more detail. This organism is present in the gut of up to 3% of healthy adults, but it can cause illness if the balance of gut bacteria is altered with antibiotics or if the bacteria are introduced to a patient. Symptoms range from mild to severe and in some instances can be life-threatening. C. diff is spread via the fecal-oral route. This slide illustrates how spores released in the faeces can contaminate the environment, staff hands, care equipment and subsequently a patient. If you suspect a patient has C. diff, isolate the patient with their own toilet, take a stool specimen to test for C. diff and follow the C. diff policy. There are 2 tests performed on liquid stool samples to look for C. diff bacteria. The stool samples must be between types 5 to 7 in order for the test to be undertaken. A PCR result suggests colonisation or carriage of C. diff rather than infection. However, the patient is an infection risk whilst having diarrhoea and must be isolated under enteric precautions. A toxin result suggests infection and timely treatment. Patients pose an infection risk and must be isolated under enteric precautions. They must also have any current antibiotics or proton pump inhibitor treatment reviewed. Advice on treatment can be sought via the antibiotic intranet site, C. diff guidance, C. diff nurse specialist or the microbiologist. If fidaxomicin treatment is required, please note that this is a time-critical drug to be given within the hour. Precautions may be stopped once the patient is 72 hours clear of symptoms and passing form stool. The side room must undergo a decontamination in line with policy using hydrogen peroxide. If this cannot be undertaken out of hours, a HAZTAB clean must be performed and hydrogen peroxide used at the earliest opportunity. Outbreaks of infection can be declared if 2 cases are linked within a 28-day time frame. Therefore, you must keep clutter to a minimum to facilitate adequate cleaning. NUH must report to our regulators all cases of C. diff infection. This slide illustrates the number of cases reported year on year. Whilst we have been successful at reducing our rates of C. diff and MRSA, new challenges require our careful management. The rise of gram-negative organisms, such as CRE, is a worldwide threat. These organisms are highly resistant to carbapenem antibiotics. It is important that we continue to tackle antibiotic resistance with sensible prescribing and careful management of cases of CRE. Assess and identify any patients who meet the screening criteria on admission for CRE. Familiarise yourself with the CRE policy and liaise with the Infection Prevention and Control team if you have a patient who meets the criteria. To screen for CRE, a rectal swab or stool specimen is required. Also include any wounds or manipulated sites, such as peg feeds, in the screening. Patients who meet the CRE screening criteria or have previous confirmed carriage must be isolated under wound, skin and enteric precautions with their own toilet facility. You must use long-sleeved disposable gowns and gloves when caring for the patient or their environment. These should be removed in the room and hands decontaminated before leaving. Outbreaks of CRE can occur and environmental contamination is a challenge. Therefore, maintain good communication between any receiving department and ensure CRE precautions are maintained. For confirmed cases of CRE, hydrogen peroxide should be used to decontaminate equipment and the side room facility if the patient is discharged or transferred. Cleaning is everyone's responsibility. When we clean, we remove the reservoir where organisms can flourish. This is essential as some organisms can survive in the environment for several months and have the potential to cause harm. A range of cleaning products are available for all clinical areas, and you should work closely with your cleaner when planning a clean, particularly post-outbreak cleaning. This slide illustrates the difference between cleaning, disinfection and sterilisation. The level of cleaning will depend on your clinical area of work and procedures. Cleaning is always a prerequisite for any other level of decontamination. Always assume blood and body fluids are infectious and wear appropriate personal protective equipment when dealing with a spillage. Use the appropriate cleaning agent in line with policy. Report spillages outside the clinical area via cleaning services. Be aware of what items are single use and look for the symbol 2 scored through on packaging. These items should only be used once before being discarded. Single patient use items may be used more than once for that patient but should not be shared. If you're unwell, you should refrain from work. If you are having diarrhea or vomiting, you need to stay away until you are 48 hours clear of symptoms. All staff are encouraged to take up the annual flu vaccination to protect you and your patients. Finally, you can obtain further information via the IPC intranet site, NUH policies, procedures and guidelines, the Infection Prevention Control Team and your Infection Control Link professional. This concludes your IPC refresher training. Thank you for listening.